we're going to look at, we're going to focus on perinatal mental health, which includes mental well-being during pregnancy and up to 1 year after birth. I know here in Jersey we cover up to 2 years postnatal, but the actual perinatal period would include 1 year. As midwives, you're often the first professional women trust with emotional concerns, making your role vital in early awareness and support. So we're very well placed to care for these women. By the end of this session, I'm hoping that we all feel a little bit more confident in recognizing common perinatal mental health needs, understanding your role as a midwife, and knowing when concerns need escalation. We also reflect on self-care, as emotional work affects us all too. Definitely does. So why does perinatal mental health matter? Mental health difficulties are really common in the perinatal period. Many women share distress with a midwife first, often fearing judgment or safeguarding. Compassionate, skilled midwifery care can significantly improve outcomes for mothers, babies, and their families. We are in the position where we can build relationships with these women, increase trust. As a midwife, you are the intervention, building that relationship with them, that therapeutic relationship where they feel safe to open up during the most vulnerable time of any woman's life. So it's really important. Understanding the pregnancy brain, understanding what's normal is what helps us acknowledge and recognize what is abnormal. So pregnancy causes widespread changes in the brain structure. Women lose up to 5% of their grey matter across 94% of their brain. And this is caused by a process called neural pruning. So it's making the brain smaller, but to be more efficient, linking the right and left hemisphere to increase speed. It's the exact same process that happens in a teenage brain, where non-used neural networks are trimmed like you're trimming a hedge, essentially. And it's getting rid of old neural links that we don't need anymore or that the brain deems as unnecessary. Having that much grey matter being lost, that is actually what causes mum brain. They can get brain fog, they can feel like their brain isn't functioning at, you know, what they're used to. Understanding this actually helps us reassure women and reduce unnecessary worry or self-blame. What women may notice: forgetfulness, reduced concentration, mental fog, increased emotional sensitivity. So while neural pruning is happening, the amygdala is growing at the same time, and the amygdala is responsible for our emotional reactivity, for our emotional sensitivity, for our memory formation. So if you think of a woman that's really high functioning, think career women that manage a whole company, all of a sudden their brain isn't functioning at the rate that they're used to. That can cause an awful lot of frustration as well. And what is a normal process, while difficult, people can think that it's a mental illness when it's not. So we need to normalize what's actually normal so that we can distinguish what's abnormal and who's at risk. And don't get me wrong, when I say normal, I don't mean easy. It is definitely not easy. Hormonal changes in pregnancy. When women experience forgetfulness in particular, heightened emotional sensitivity, these experiences are common. It doesn't automatically indicate mental illness. But when we look at hormonal changes as well, by 10 to 12 weeks, the placenta becomes the main source of progesterone and estrogen. So without an external trigger for stress, when the baby has a growth spurt, the placenta pours hormones into the bloodstream. Our hormones are like a symphony in our bloodstream. Those hormones do cross the blood-brain barrier, and they directly affect mood, memory, and emotional regulation. And the difficulty is if there's no external trigger, like if you're driving and someone cuts you off in traffic and you get angry about that, you understand your anger is because of the external trigger. But if silently, without you knowing, the placenta is pouring hormones into your bloodstream and you're having this complete chemical disruption in your body, and there's no external trigger for why your mood changes, that can make women quite fearful as well, because they don't understand why they're suddenly emotional or short-tempered or feeling sad, and that can make them feel like they're losing control of their body. And that's really, really difficult to hold when fatigue sets in and you're having an emotional day and there's no particular reason for it that you can see, because it's all happening internally. That can make women feel really, really lonely, and that it's only happening to them. So I find a lot of my work is educating moms on what is actually happening within their body, and that removes the fear for them then. Doesn't make it easier, but it can just remove some of that anxiety of, oh my God, 9 a.m. I was fine, 10 a.m. nothing's happened, but my world looks different and I'm really confused by why. So the more we can normalize this, the easier it is to help moms emotionally regulate and to be very compassionate and patient with themselves as well. So hormones and mental health. Our hormonal changes can increase emotional sensitivity. Fatigue and stress tolerance may reduce. I say it will reduce. Increased vulnerability for mental illness. Psychosocial context and support are key. So when women present to the clinic especially, we need to distinguish between what's a bad day and what they're considering to be a negative life. Sleep is the first to go, yet it's our first protector of our brain. We need to distinguish, and it's about being curious. So when someone presents tearful, there will never be more referrals to the perinatal mental health service than being tearful at an appointment. But it's about being curious and, you know, what is happening in your life. And the more we build a relationship with those moms, the more likely they are to disclose to us what is actually happening. Vulnerability from reduced stress tolerance, it doesn't equal mental illness. We need to look at their support systems, what's happening in their life. Have they had sleep? And that helps us determine mental well-being. Matrescence, this is our bread and butter as midwives. If we can get our heads around this, this is actually what explains so much to the moms. So matrescence is a term coined by Dana Raphael. She's it's the man, I think, anthropologist. It describes the developmental transition into motherhood. They compare it to adolescence. It begins in pregnancy and continues postnatally. It involves changes in identity, relationships, and priorities. So if you take a teenager, they have 10 years roughly to go through the puberty journey. They have physical changes, their body's changing. They have chemical changes, their hormones are changing. Neural pruning, the exact same process as the pregnant brain, is happening for teenagers. Their role in life is changing. Their identity is changing. But they have a good 10 years where socially we expect them to get things wrong often. And we expect it to be difficult. And we trust that with support, and we love them through, and we accept that they make mistakes, they'll come through it and they will develop into an adult and they will be fine. A mom, she has 10 months to experience more change than a teenager has in 10 years. And this is what we're losing sight of. So I'm very excited about this research that has come out. It's forever evolving and it's helping make sense of the actual transition into becoming a mother. A mom will have physical changes. She will have chemical changes. We've seen the brain changes alone that happen in a mom. Her role is changing, her identity is changing. She's trying to figure out who she is. She's adding the title of mother, but she may lose her idea of who she was. And a lot of moms do grieve their old life while they're transitioning into what their new life means. And that takes time. And they should be allowed to go through that. But as a society, a mother has to be forever happy. She has to be only excited, only grateful, and make no mistakes. That's not reality. And if it was reality, I wouldn't have a job. So it can be really difficult. What we need to allow moms to do is hold two realities at the same time. She is allowed to be grateful and terrified. She is allowed to be happy and hate pregnancy because it's really difficult. And social media can help us connect, but it also encourages, miscommunication, misinformation, where they can get conflicting ideas of what it means to be a mom and what the expectations are. So when we meet moms, we're able to normalize this and be curious with them in their appointments, help figure out, where their social network lies. And once we really understand this, I have found in my practice has helped mothers more than anything in understanding what's happening in their bodies and actually removing a lot of anxiety for them. Because quite often women are isolated, they're too afraid to talk about how difficult it is. If you have someone that's had a lot of miscarriages or they've had a long IVF journey, they might feel they're not allowed to struggle and that they're not allowed to say they're not enjoying the pregnancy, when of course they are. And we need to be really compassionate in helping them be compassionate towards themselves as well. So huge process that's happening there. Why it matters in midwifery: we're normalizing emotional upheaval and identity change. It's going to reduce stigma and self-blame. And self-blame is one of the biggest risks of depression, because they can keep it in, not disclose anything, and this guilt and shame spiral can increase so much that it can affect bonding when baby's born. It helps distinguish normal transition from mental illness. So when we look at mental illness, we're looking at how their functioning is affected. When we look at anxiety through evolution is why we're here as a human race. We need anxiety. It's what keeps us safe. It's when this becomes maladaptive, our fire alarms are going off all of the time, where it's affecting if we can go to work, if we can eat, if we can sleep, socially isolating. This is when it's maladaptive and we need to intervene. But having some anxiety, we need that. So it's differentiating between what is helping us. Anxiety, the purpose of it is to make us pause. It's to keep us safe. But if it is firing off alarms all of the time, that is when we need to intervene. It helps us support compassionate, trauma-informed care. So at least thinking, actually, yes, pregnancy is really difficult. Your body is no longer your own. Your brain is changing. It takes 12 weeks postnatally for all of those hormones to wash out of your system. It takes 9 to 10 months for your body to return to normal. It takes 3 years from the birth of your last baby for your brain to go back to what it was pre-pregnancy. And that can be really frustrating if you don't understand what's happening in your body. So when we look at common perinatal mental health conditions, 20% of all moms will experience a mental health issue in their pregnancy and postnatal period. We look at depression, about 20% that we know of have anxiety and depressive disorders. PTSD, bipolar affective disorder, postpartum psychosis, obviously going up in severity. Postpartum psychosis happens about 2 in 1,000 births. So while it's not common, it is an emergency. And, you know, I think future training, we can go into each one of these in more depth because there's so much in them. But when we are looking at the midwifery role and the student midwife is usually the first person these moms will come to and feel safe with, because you've more time. And I would use that time to gain the support of your midwives to explore these things as well. Women have various, we look at ACEs. So an ACE score looks at previous childhood trauma. You can do an online questionnaire that will give you your ACE score. So it looks at if you had a parent with mental health issues, a parent in jail, addictions in the home, abuse. You can score your ACE, and the higher the ACE score, the more at risk you are and the more vulnerable you are of having a mental health issue yourself. So these are all pre-screening tools that we can use. Post-traumatic stress disorder, that can be from anything really. Being pregnant is one of the biggest triggers for reflecting on your own childhood, your own parenting experience. And I find that a lot of moms are quite surprised by this, and they feel like they've done so much work in their life and they should be over, in inverted commas, whatever their traumas were. And then when they have a baby, it can be like they're holding themselves, and it can actually re-traumatize them again, because they're seeing how vulnerable and innocent a little baby is, and they love them so much. And to think, it's like a cognitive dissonance then when they see their baby, of how could someone mistreat them. And it's trying to separate those, normalize the reaction, because that is a normal reaction to have. It makes you question, on top of all of the normal changes that are happening as well. And a very common, obviously, birth trauma, if they've had a previous poor decision, or not poor decision, sorry, poor experience. Our brains will put a GPS pin in that experience, and they can have therapies, and they can, you know, really, really help themselves cognitively to get past that trauma. But when they get pregnant again, because the brain doesn't have any other experience to compare it to, it will cause anxiety in that pregnancy again, which is understandable. Our brains are trying to help us remain safe, and it will set off all of those fire alarms because of a previous poor experience. So support and compassionate care in midwifery, and giving women time and the right treatment to help them manage their anxiety, really, because a better experience is what will bring an awful lot of healing. And when I work with women with birth trauma, I will quite often say, we're not going to cure this in your pregnancy. What we need to do is maintain your functioning, support you through, because it's like with anything, if you have a bad experience and someone tells you it will be fine, you're not going to believe that until it is fine. So it is just supporting them. Bipolar affective disorder. Bipolar, this would need its own class as well. Basically, when you have any severe hormonal fluctuations, it's going to increase your risk of a relapse. So we have women who have never had bipolar diagnosed, who in pregnancy can become either manic or hypomanic. The mania is where they can't sleep, they've got excessive energy, they've an increase in risk-taking behavior. And hypomania, it's usually bipolar type 2. That's where they can become quite depressed, have suicidal thoughts. So we've got two where some can appear in pregnancy in the postnatal period for the first time. Others, they already have established bipolar and they discontinue their medication in pregnancy. to, protect the baby. But the biggest risk to every baby is an unwell mom, because without mom, there is no baby. So these women need to be managed and monitored. It is absolutely their choice whether they take medication or not, but that means increased mental health surveillance. So as student midwives, it is absolutely not your job to be monitoring bipolar. It is just to be aware for yourself that these things are here and what the increased risks might be and where to go. So when we are looking at women, the difficulties that may present, they can appear to be coping, but feel overwhelmed, be very tearful, withdrawn, emotionally flat, appear kind of disengaged. They can experience heightened anxiety about the baby. They can miss appointments or disengage. It's very common that they will minimize or normalize distress. We can see mums repeatedly apologize for being tearful. And they're like, I'm fine. And you can feel that they're not okay. Curiosity from all of us is a lot more helpful than reassurance. We can say, you're fine, it'll be fine. We might know it will be fine in time, but being curious about what is coming up for them. Time is always a luxury. We don't often have it, but having time to be curious will help them, because any number of things could be coming up for them. It could simply be sleep deprivation. They might be having triggers from childhood, from trauma. They might be fearful of the baby. Because newborns, I often feel for moms and dads actually, because, or any parent, you have 10 months roughly potentially of pregnancy where we educate them on what to worry about without giving them tools on how to cope with that worry. We have classes on shaking babies. We have classes on preventing SIDS. These are very frightening topics that I think over time as midwives we can become a little bit desensitized to, because we're so used to speaking about it. To parents, thinking about SIDS with their baby is absolutely earth-shattering, and we're not giving, in my opinion, we're not giving them enough tools on how to cope with that stress. So it could be any number of things that are coming up for them. And as I said earlier, midwives and student midwives are the intervention, giving them that 5 minutes of checking in with them, helping moms check in with them, and allowing them to feel, actually, it's okay to be frightened by this, let's talk about it. And if they needed more support, how to signpost them. And it's just creating that space. It's just a safe space where they can explore their own emotions, because they may not have anyone in their lives, depending on where they're from, that has time, really. Risk and protective factors. We look at ACEs. That is a gold standard. If they've previous mental health issues, that is a very big red flag of just extra surveillance. If they've had trauma, abuse, or loss, if they're socially isolated, if they have high self-expectations, which would be very high perfectionism traits, if they have a fear of judgment. I would see it quite often in first-time moms who want everything to be perfect, and their expectations are fed through family, friends, social media, our own picture of what we want. And when that picture isn't made and it's not met, that can create a grief, because they're grieving the picture that they never obtained. Protective factors: feeling listened to, continuity of carer, supportive relationships, clear information and reassurance. Again, it's that time. Getting to know women. It's not always possible, depending on the hospital and the trust that you're in, when I was in Ireland, you never met the same woman twice. So that's where Ireland would lack in terms of that, because it's very hard to give continuity. Whereas smaller trusts have it's a little bit easier in that regard. Community midwifery, they have a better chance of providing this as well. But really just having a calm demeanor, trying to support them as best you can, and just listening. We really underestimate the value of listening. And when we look at women who have complained of birth trauma, a lot of the time when I was a midwife in Ireland, a successful day to me was everyone was alive. There was 10,000 deliveries a year. There was 24 babies a day. You had a birth an hour. And it's obviously the other end of the spectrum that's really unsafe. That's not what we're going for. But when I moved into mental health, it's changed how I practice as a midwife. I didn't get any training in mental health, really. You were told about postnatal depression, and that was kind of it back in 2012. Whereas now we know so much more. And what creates trauma isn't the actual event, it's the meaning that they attach to the event. So quite often I will see what looks like an obstetrically scary delivery. So if a woman has a crash, general anesthetic, cesarean, I would expect her to feel trauma. And when I meet those women, they don't. They're like, well, everyone communicated well. I felt safe. I felt involved. I understood why they wanted to do what they were doing. So I felt safe, fine. I have seen deliveries where obstetrically looked beautiful, straightforward, maybe a little kiwi cup just to help rotation. And those women were genuinely so traumatized by these experiences because they said the doctor didn't explain what was happening. The midwife looked frightened. They didn't feel like they were involved in the process and they felt unsafe. So communication is free, and that is actually protective communication and making sure they're informed actually prevents an awful lot of trauma from happening. And that is something, even as qualified midwives and doctors, we need to work on and keep developing as we go. The midwife role, asking about emotional well-being at every contact. We are the best placed for having appointments with women, for having opportunities to ask questions, using screening questions appropriately. We've got the Hooley questionnaire, we've got the Edinburgh postnatal depression scale. None of these scales are diagnostic, but we can use them as just a red flag, just to, okay, do we need to have this conversation again? Do we need to keep an eye? Do we need to ask more questions? When we listen and we validate, that's where you can decipher between, okay, has she had a bad night's sleep, or is she actually really, is she becoming unwell? Recognizing deterioration or risk. If you hear women talking about self-harm, or they're not bonding with the baby, these are all things that would be signs of deterioration. Or complete disengagement if they stop coming to appointments. This gives us opportunities to escalate our concerns following each individual's trust pathways. I know each trust is different, but they generally follow the same theme. We're all working with the multidisciplinary team, and no midwife or student midwife is expected to diagnose, because I know working in mental health can be very overwhelming. You know, it carries one of the highest risk profiles of any mental health service, because you're dealing with two lives at all times. So curiosity is free, communication is free, and that is a skill that we will continue to develop. And I think raising awareness now as student midwives, it's going to set you so far apart from everyone else. I wish I knew this as a student. You know, I'm 38. I've been a midwife since I was, 26. It's taken a very long time for midwifery to push this far forward when it comes to mental health, which is amazing, but it actually puts you as a student midwife so far ahead of everybody else. And it's a very exciting time with everything we're learning about the brain and all of the interventions they're putting in place to support women at this time as well. It's a really, really good time to be coming into midwifery. How student midwives can help moms: ask open questions and really listen. Try to avoid yes or no questions. Normalize emotional and cognitive changes. And I think for students especially, understanding what's normal is going to give you the confidence to be able to assist moms in reassuring them, because you can't reassure what you don't know. We're normalizing even telling them about the brain changes if they're really frustrated, and then it, you know, that gives you an open dialogue with them where you can explore a little bit deeper. Validate women's experiences. Pregnancy is difficult, full stop. I have not met a woman yet that has sailed through it. Encourage women to accept support, avoiding minimizing or dismissing feelings. This is in particular what I hear moms struggle with from their families, especially. If they have a partner or a family member, it's very difficult when you're trying to support someone you love and they're in distress and you can't fix it. What they need is someone to sit with them and help them hold that anxiety or just give them a hug. But a lot of people in our society will say, just don't worry about it, just don't think about it, you know. And if that were in any way effective, I think, you know, none of us would have jobs. So it's just acknowledging, okay, it's really learning how to sit with people. If someone says I'm having a bad day, it's like, okay, I'm sorry you're having a bad day, and allowing that feeling to be, instead of trying to fix that feeling, because the more we acknowledge it and create space for it, the less time people are stuck in that emotion in the first place. And no one does that maliciously. It comes from not knowing what to do, really. You know, if I'm really anxious, well, I can't fix it, so don't be anxious. That will be a very, very common one that I hear. Presence matters more than having the right words. Do not worry about saying the wrong things. Sometimes there is nothing to say other than sitting with them. And it's just allowing that space and that time. And that comes with time. You know, when you grow in confidence as a practitioner, you'll recognize these things. You'll be able to read people's body language, and you get more and more confident with it as you evolve as a student midwife and a midwife. And it's just being patient with yourself as well. Risk safeguarding and escalation. Be alert to thoughts of self-harm or suicide, thoughts of harming the baby, rapid deterioration in mental state, psychotic symptoms, and then escalating as appropriate. Again, none of you are expected to diagnose any of these things. If you hear someone say, you do a Hooley questionnaire or the Edinburgh postnatal depression scale, and someone ticks yes to the self-harm question, you're escalating it to your midwife. That's all you need to do. You're just letting someone above you know. So try not to stress too much about that, because it can be very overwhelming as well. But I would definitely use time as a student midwife. Use the support around you. The emotional impact on student midwives, it can feel very emotionally heavy. I know if I've had a really heavy day myself, I need to come home to silence and not talk to anybody for about 30 minutes. It can trigger personal experiences. None of us were born in a vacuum. We've all had lives. We all have our own experiences. Some of us have children, we all have our own lived experiences, and we don't always know what's going to trigger us. It can create feelings of helplessness. Watching someone in distress is a helpless feeling if you can't take an action. And this is where partners struggle as well. If they can't take an action, we all differ in our ability to tolerate distress. And that's what anxiety is our tolerance of distress and the unknown. And that all of those things can lead to emotional fatigue. Emotional responses are human. They are in no way a weakness. I'm far more concerned about someone that can't show emotions than someone that gets upset. Being upset and being emotional is reassuring to me, working in mental health. Caring for yourself. Self-care is part of professional accountability. It includes using your supervision and reflective practice, talking about difficult encounters after the event, having a debrief, recognizing signs of stress early, where if you find you're getting anxious before you come to work, if your appetite is disrupted, if you can't sleep, if you're having ruminating thoughts, any of the things you would look for in the moms you're caring for. If you are feeling them yourself, it's having a pause, because this is not easy work and the support is there, asking for help when needed. Sometimes just talking to someone about it, it helps your brain process the event or the question, or even just sitting with yourself and seeing what's coming up for me now, what is coming up in my body, and having time to explore that. Reflective practice is a really good tool, because studies have shown, even journaling, if we journal our feelings, you are telling your brain that's ruminating, I'm taking an action. I am addressing this anxiety by journaling. And it actually helps reduce the your emotional reactivity, and it helps reduce the ruminations in themselves, which then helps you sleep. So it's using these tools, and they're all free. It just, you might feel a little bit silly when you do it first, but it really, really helps. And when you understand why it helps the brain, it's over here waving, saying, please address this, and you can be distracted during the day. And they say insomnia is the revenge of the thoughts you refuse to have during the day, which I quite like. Support available to student midwives. You have your practice supervisor and assessor, university wellbeing services, occupational health pathways, trusted peers. You are not expected to cope alone, and please do not try to cope alone. You will meet women at some of the most vulnerable moments of their lives, and looking after yourself enables you to look after them well. And the picture that we use is, if you are the pilot of your plane, your home, your family, your friends, everyone you care about are the passengers of that plane. What happens if the pilot becomes unwell? This helps people restructure and reframe the priorities of care. You have to care for yourself first. The plane and the passengers will be fine if you are cared for first.